So, good morning. Welcome everyone to our Grand Round. This event is a partnership of the Medical and Teaching Board of our hospital and the Medical School of URGS. And today it's an honor to welcome Professor François Maillot. He is the head of the Service of Internal Medicine at the Regional University Hospital Center of Tours, France, and a professor at the Reference Center for Hereditary Metabolic Diseases at the University of Tours, France. Besides of Professor Ricardo Xavier, head and professor of the Laboratory Diagnosis Service and professor of the Rheumatology Service, and Professor Jonas Salt as well from Medical Genetics and the Neurological Service at HCPA. Professor Maillot will present us some of his data and the French national data on rare diseases. Let's enjoy this great session.
Thank you very much, Ida. So I am very happy to be here, and I want to thank you for your welcome. This is my first time in Brazil ever. So, and I came with the storm last week, but be sure that I did not bring the storm. Or if I bring the storm, I will get back with the storm, okay? So beyond, and I would like mostly to thank the organizing committee and all of you for being here. And thanks to Professor Ida for a very kind invitation. So beyond that enigmatic title, I will try to explain to you. I will talk about rare disease, about our organization in France, what we have done specifically for rare disease at the national level and also at our local level in our university hospital, how we are organized, what we do. This is very simple. So, but before I start, I will just to describe to you very briefly the health situation in France. So France is small, as you see the surface here. If you compare to Brazil, this is very small. And we have 60 million people in a small area, so it is very dense. And this is some data from 2022. Our birth rate is 10.6 per mil inhabitants, but as you see, it decreases over time. But still, we have a positive balance because the mortality rate is 9.8%, and the first cause of mortality in our country is cancer, then cardiovascular disease, respiratory disease. The fourth one is accident, suicide, and anything. And our infant mortality rate is quite low, 3.9 per 1,000 newborns. And that means before the first year of age, 50% of them being on the first week of age. But we don't improve much because this is stable over 20 years. And we are trying to improve because we are the 20th, at the 20th rank of Europe regarding this mortality rate. The healthcare organization in France is dependent of the French Minister of Solidarities and Health, and there is a special department dedicated to rare disease. We use the definitions that I think you use in your country. So rare disease is defined as the prevalence that is below 1 of 2,000 people. That means that we have more than 3 million people affected with rare disease in France and 27 million, this is an estimation, in Europe. So I will try to explain that story of paradigm shift. because this is my point of view. This is my paradigm shift, really. So when people think about rare disease, usually they are pessimistic. They only talk about issue. These rare diseases are difficult to diagnose. There are some diagnostic delay. There is a lack of therapy. We miss a lot of drugs, and our organization is poor, and many other issues that you can hear about this rare diseases. But I would like to be more optimistic and not to think about issues, but to think about opportunities. And I have made a list, and we can see things to improve diagnostic procedure. We can also try to develop new healthcare organization to be more efficient with these patients and this disease, and get new fundings for research, and so on and so on and so on. And this is why I think, because we thought like this, that we have set up a French national plan for rare disease. So PNMR is French, Plan National Maladies Rares. So, okay. But what we have to explain, because this is very important, that it came from the patients and the families. We know, I will tell you, once upon a time in a small country in Europe where people fight a lot, always fight a lot, patients, families, and patient association, along with healthcare professionals and researchers, they put the pressure on the French government to get a specific national plan for rare disease. But I have to say that mainly it comes from the patients, and this is very important. So after a long period of fighting, struggling with that, in 2004, there was a public health policy statement that has included rare disease into the 5 priorities of public health. So that was a great victory for patients and families to get this statement. Don't ask me about the other priorities, I don't know, but rare diseases were included. So this is why the first national plan has started in 2005 and was set up for 4 years. And the first thing that we did was to create some reference centers and what we call competence centers. I don't know if this is exactly the good translation, but for us, what does it mean? Reference centers, they are funded, they get money for their to function, and competence center, they don't get any money, but they do the job as well. And there are many goals. I will not describe everything, but organize screening and access of care, teach about rare disease, develop information, and that was the creation of Orphanet. I think you all know Orphanet. So Orphanet was first a national website, and it has been developed in Europe, and now it's international, and is mostly due to a researcher, maybe you know, Ségolène Aimé, that was very involved in the development of Orphanet. So, and there are many also goals, and the funding of the first national plan was a little bit above 100 million euros. That was the start. So at the end of 2008, we have evaluated things, people were happy, but we had to wait for 3 more years to get the new and the second national plan. And there are also many goals in this plan, and you can find it online, of course. But the main things I have written for this presentation that we have created and we have labeled rare disease networks. I will explain what are these networks? So these networks, there are 23 reference networks, and they are all connected to European reference networks. It depends on the disease. So we have, I will take some example. For example, here, this is cystic fibrosis. This one is amyotrophic lateral sclerosis. We have something about cardio. Philnemus is about myopathies. So this is a good coverage of many diseases, and the one I am involved in is this one, J2M. This was the inborn metabolic disease, and I will explain what we do in this network. So after the second network, it's quite logical. We had the third national plan starting in 2008 and just ended in the last December. So that was something very ambitious, diagnosis and treatment for everyone. And the main goals were to get rapid diagnosis for everyone, to have a short diagnostic delay as much as possible, to encourage innovation in therapy, improve quality of life of affected person and autonomy. So you see there are many goals, clinical, research, and everything. Increase the sharing of knowledge and clinical skills. This is what I will explain how we do that. And also something very important, because we were quite late in newborn screening, because at that time, in 2008 and up to last January, we only screened for 5 diseases. So we added 7 more from January, and we think we should be able to include 5 more diseases by the end of this year. So this is quite important. But you see, the funding has increased a lot with time, because now we are just about 800 million euros for this 4th year, the 4 year of the third national plan. So the more you want to, the more the money you have to put on the table, of course. And besides this plan, many things have been created alongside, like some website for the patient when they can get informations to know where they can be follow-up, for example, where they can be, where are the specialists, where are the reference centers. There are some things about diagnostic procedure, the networks I will describe later, and everything. There is also an association of the associations. So more than 200 patient associations belong to the Alliance Maladies Rares. And one thing which is very important, we have also every network has works of national protocols for rare disease, and I will show you now. So we call PNDS, it's a French acronym, and we have, so far, I have checked this morning, I was not sure, but we have covered 358 diseases so far. And you can see some example. For example, here is a metabolic disease, homocystinuria. Here, this is giant cell arteritis, Cornelia de Lange syndrome, and many others are covered. And you can go to the HAS website. This is Health Authority website. And I don't think there is any English translation, but maybe. And it's very extensive protocol. And now, as you've seen, the last plan ended in December 22. We are waiting the 4th national plan. We don't know when it will be launched, but we hope that it will be as soon as possible. And we just know that the main goal is to improve synergy between care and researchers. I don't know what does it mean so far, but we are waiting for. But for sure, we will have a fourth plan. And you see, this is very important, that there is an evaluation at the end of the plan. From the evaluation, we set up a new plan, and I think it will last forever, or as long as possible. Okay? So now I will talk about my specialty among internal medicine. So I look after adult patients with inborn metabolic disease. And our network is called J2IM. We have one national reference center for coordination in Paris, in Necker Hospital. And the coordinator is Professor Pascal Delonlay, who is a pediatrician. And we have some general IMDs reference center in Lyon, Marseille, and you see Tours, maybe the smallest city to have a reference center. So we are proud of this because we were in competition with very big university hospitals. So we were lucky to get the labeling. And there are also some specialized metabolic centers. For example, there is one in Paris with glycogen storage disease, one for porphyria. They are mainly based in Paris for this one. And there are also competence centers across the country, and you remember the difference. The reference center, they got some funding. The others, they got their hands and their brain. Okay? So for you to know, for our center, we have almost, not only, but almost 200,000 euros a year for the daily things. So this is just a map to show you the repartition and to show you where I live. Here, you see, is along the Loire Valley. So, and this, what I wanted to show you, this is France. We call France the hexagon, and we have quite a good coverage over the country, because you are not used to here, but French patients, they don't want to travel. They want to be seen very close to where they live. This is why we have set up this coverage. So now in our center, we see all these happy guys. So this is me, and this is my friend François Labarthe, François as well. So you have to be a François to deal with metabolic disease, in case you... And then he's a pediatrician, because this is quite different, I think, of what you have here, because most metabolic patients, I know they are followed by geneticists, medical geneticists, but not only, I guess. And in France, children are seen by the pediatricians, and the adults are seen by the internist, but sometimes endocrinologists or neurologists, we don't mind, as long as people are involved to look after patients. So we called our team Totem, and we are very proud of this logo, 2 teams for metabolism. So our specificities, and this is something I like very much, we have a multidisciplinary team with physicians, pediatricians, internists, dietitians, biochemists, geneticists, there is more, neuropsychologists, clinical psychologists, and we have a very important person, is the coordination nurse. She programs everything for us, and we have weekly meetings all together, and this is important to share. We talk about children, we talk about adults, we talk about any issues we have with patients or research or everything. And what is specific is that we have for more than 20 years, and I think we were the first in France to have a specific structure for adult patients in my unit. So I have started metabolic disease in 1999, and I will show you what we do. We are focused on diagnosis in adults at any age, because we do believe, and I show I showed this morning with the internal medicine residents here that you can pick up some patients even if they are adults or even if they are old with metabolic disease. And this is not only about children, but of course we have organized a transition from childhood, because I will show you some data about. We have also rare disease platform with the outline. That means some patients sometimes they get lost. They know they have a specific disease, but they don't know which people they have to see, in which service they have to go. So they can get some indication from that. And we have also a social worker on this platform. This was a specific call, and we get the funding 2 years ago for this platform. There is no platforms in any centers. We do some research. I will not talk about beta oxidation disorders. And me, I am more focused on phenylketonuria in adults, about the natural history and disease and so on. And of course, we have some national and international activities. And if we don't have, I will not be here today. And we were, François Labarthe and me, we were also involved in the working group to improve the newborn screening program. So why I will show you. Sorry, this is in French. We have, besides the national plan, a national database for rare disease has been created, and we have the obligation to put in this database every patient we see. But not only patients, but every patient in which we suspect a metabolic disease. Every time we see the patient in outpatient, if he's admitted, if we have a phone call, if we have an email, we put everything into the database, because this is very important, because the evaluation, the health minister will look only at this. They will extract the data from the national database to evaluate every center. So this is very important to do that almost every day. But what I will show you is the age of diagnosis of, this has been done, the data of last year, I guess, over, I don't remember, maybe 10 years, or I don't know, I don't remember. But you see that most patients are diagnosed during childhood, and most of them during the first year of life. But you see that there is also a significant number of patients that can be diagnosed at an older age. And this is very important to consider. And when I say at any age, that includes older people, and I show you some example of our local experience. We have diagnosed some, for example, urea cycle defects in a 82 years patient, and other disease. You see that in older people you can pick up some diagnostics. And now we have a very, I hope, nice systematic literary review about IMDs in elderly ongoing, and it's nice collaboration between here and my service. So we have medical students from Porto Alegre involved, and a European student at the same time, and we coordinate that with Professor Ida. Just a slide to focus, because I do believe that internists are important because they are used to this diagnostic approach, and because I don't think only internists can be involved. I think many specialties, of course, geneticists, neurologists, and rheumatologists, I think also. But mainly because the internists in France, we are used to deal with multisystemic disease, and there are, I think, many metabolic diseases in which the clinical expression is systemic. So this is why I do believe. And how do we do? This is a very short representation of inborn metabolic disease. I will take an example. If you have someone who have a brain dysfunction, as well as a liver dysfunction, for example, as well as a muscle involvement, if you can check, and you will maybe find that there is an energy problem. So you will look at an energy defect disease. So this is how we do, and this is, I think, the way we see things, and this is what we've done for other diseases. For systemic, inflammatory disease, it's the same. The other aspect we have developed, I told you, is the transition from childhood to adulthood, and for me this is very important. I told you, one of the first centers, or maybe the first centers, to organize things about this special aspect. And this is important because if you see that's again the national database along the years, I think more than 15 years, you see that this is the patients that are seen in pediatrics or adult department, and there have been a shift over the years, and now we have more adult patients to look after as compared to children. And if you look at people, what we call feel active, I don't know how to translate. It's a person, I think the definition, they have been seen maybe twice a year in a specific center. This is the same. Sorry. We have more adult patients than children. So this is why also, again, we have a specific adult organization in France, and we fight to get more money for the adult center, more physicians, and so on. And we were involved, François, my pediatric colleagues, and me, we were involved in the publication of something about the transition. This is in the French journal published in 2018, but the paper is in English. And we describe what we think is the best organization to organize for the transfer of childhood. So this slide is quite complicated, but it can show you. I will let the slides anyway. That we need some resources, of course. You have to have someone to look after the patients. You have to have a very good communication and coordination between pediatric and adult reference centers, and I think that we have in my center. And what we do is this: we have joint appointments with the pediatric. So I go to the pediatric hospital to see the patients, and my colleague come when the transfer is done. And I will insist that transition is a process, transfer is something different. It's just to get a new appointment to the adult service. But transition is a long process, and the pediatricians, they start to talk about this transfer from the age of 12, usually. So they prepare the patients and the parents, because they are very anxious about this transfer. The pediatricians are nice. The doctor for adults, they are not nice, you see. And there are many colors. You see paintings in the pediatric wards. And the adult services, they are gray, they are white. Well, it's sad. So they are very anxious about this. So we prepare things a long time before, and I think this is the right way to do. Another thing which is very important is that we only transfer patients in a stable condition. if there are some relapses, crises, or we wait, and we try to get that before, okay? So this last slide, you see me some years ago with my friend François. This was a metabolic cooking session, so I was trying only to prepare some, I think so, low protein mayonnaise or something like that. And you see that young boy is now my patient. I think he's 20. And so this is, I think, a nice story to show. So I thank you very much for your attention. This is my hospital, just to show you. I think you know this place, and I will be happy to have questions. And if you need anything, you can also ask me. This is my email address. Thank you very much.
Thank you, Professor Mayo, for the lecture, great lecture. You can have your seat. And I would like to invite Professor Ricardo Xavier and Professor Jonas Sauti to join us. Okay. But before I give the microphone to Jonas and to Ricardo, I just want to make some comments about how rare diseases are seen in Brazil. We have a law, like a national policy for rare diseases. It was established in 2014, okay? It's different from the French model because it's not something that is changing along the years. So we have only this first version of the law. And according to this guideline, we also have reference centers for rare diseases in Brazil. And if you paid attention to the presentation, Professor Mayos told that they have 23 reference centers in France. And this is amazing because maybe this is a coincidence because we also have 23 reference centers in Brazil. So you can imagine that we are much bigger than France, and we have only 23 reference centers. It's not like in France that we have like an homogeneous distribution across the country. Here, most centers, they are located in the south and the southeast region. Okay, just I think a month ago, it was created the first center in the north region of Brazil. The other thing that it's different is that the reference centers in France, they are organized by disease or by a group, the disease, such as the inborn metabolic disease. This is not the same thing here. Here, a reference center for rare disease should be able to see every rare disease, okay? Although we have a classification in genetic or non-genetic rare disorders, if we have a reference center, we are expected to follow patients with metabolic or chromosomal disease, for instance. And my last words will be about the health system in Brazil or the health situation. You also see that the infant mortality rate in France is much lower than ours. Here is 11.9 per 100,000 inhabitants. In France is 3.9. But even though we have a much higher infantile mortality rate, the main cause of the infantile mortality rate are congenital abnormalities. So we know that not all congenital abnormalities, they are rare, but much of them are rare. And if we want to decrease this, we have to understand the rare disease issues or opportunities as a way to improve the health quality in Brazil. Okay, so I will end, and I think I will give you the microphone, Ricardo.
Okay, good morning. I'd like to thank for the invitation to be here today and to meet Professor Milo, Francois, if I may. It was a real pleasure today. We had some talk and I had the opportunity to show our central lab, Serviço Diagnóstico Laboratorial, which we're so proud of here in our hospital. As a rheumatologist, I've been dealing with rare disease for a long time. Usually what we call in the past rare disease were mostly connective tissue disease, which was autoimmune disease, like lupus, systemic sclerosis, the dermatomyositis, the systemic vasculitis. But since during the 90s, there was description of the genes and molecular pathway involved in familial Mediterranean fever. And since then, which involves the innate immune system. So there's a new class of diseases appeared in our field, which is so-called the autoinflammatory disease. And each year, we have descriptions in the Congress of 2 or 3 new autoinflammatory diseases. Like we have more than 72 genetic modifications now with some of this autoinflammatory disease. So really expanded our field and how to deal with this disease, how to diagnose this disease has been a real challenge for us. And so very much involved in rare disease right now. And also 3 years ago, a new form of autoinflammatory disease that are not genetically defined by germline mutation, but by somatic mutation, is the VEXA syndrome. So a new class of disease, rare disease also includes. So it's been a real challenge for us. So one of the questions I would like to ask Francois is, I didn't see autoinflammatory disease. There's a specific network for it. And one thing that we're starting to think about how to deal with this, so many different diseases and genetic mutations. If there's any, if AI, artificial intelligence, could be one tool for that, if already being used in France to identify this disease and to give us some guidance in how to evaluate and how to diagnose them.
Okay, so about your question about autoinflammatory disease, there is a network which includes in the same network autoimmune disease and autoinflammatory disease. So this is the same centers. And for example, in my service, we have a competence center for that. We are only a reference center for inborn metabolic disease. And your second question was about intelligence, artificial intelligence. So not really. Maybe it will be in the 4th plan. Not sure yet. But I try with different things. There is an app, IEM based, that you can use for diagnostic procedure. If you don't know, you have no idea, you can put the symptoms, but it doesn't work very well, I have to see. So maybe ChatGPT will be the next tool for us. I don't know, but well, I think we will develop. This.
Everyone who is watching us, even virtually, please, we intend to do something very interactive. So if you have questions, please let us know, okay? And I have to point out one thing that I think I didn't mention, but I know that, of course, everyone knows here, that our hospital is the only reference center for rare diseases that we have in our state, okay?
So good morning, everyone. Also, thanks for the invitation to be here. Thanks, Professor Francois, so I also call you Francois, okay? My point is, just a previous comment. We have this national plan in Brazil, but it's not only necessary to have the plan, but we have to implement novel things like technologies and exams, and sometimes you have the plan, but you don't have access to the exam. So this is something that is ongoing, and you have the policy. It's not the same as just have access to these exams, and in the moment we have some troubles with this regard. But my point to you is like patients can say to the legislator, oh, I have a rare disease, and they can complain and can push them to build these national plans, as you just mentioned. But sometimes they will complain that the physicians doesn't know their problem. So they're going to go to a physician, and the physician just doesn't know. I have this disease, and I don't know. My physician doesn't know what I have. And this can also be a problem. And you are in the internal medicine field. So my question to you is, how do you engage the other physicians in the adult field into the rare disease issue? So how are you dealing with this point? And also not only the physicians, but also I step back in the undergrad. Like, is there any change in the medical curricula to have more information about this disease so we can perhaps tackle this issue? So could you comment on this regard?
So I can comment first your last question before I forget. No, we didn't change anything in the medical studies so far, and I think this is the opposite. Now we have a new grading system for the knowledge of the medical students. So we have reduced the basic medical knowledge, so there is no space at all for rare disease. So I think so. But there is a specific course, which is something, it is inter-university course about inborn metabolic disease. So we encourage people that are interested. You know, it's mostly by chance or by meetings. Maybe here today someone, a student or a resident, will be interested by inborn metabolic disease, and he will ask to get to be involved into. I don't know if you have a specific course. Yes, yes. So this is and what we have done to encourage people. We have created a national group. So we have a national, like here in Brazil, you have a national society for inborn metabolic disease. So we have this, and we have. This is not separate. This is included in the National Scientific Society. We have a group dedicated to adults. So we have meetings twice a year, and we have, I think, we have many new young physicians now, and I'm not really. I am involved in the national course. But the organizers, they told me that now there are more physicians for adults than pediatricians attending the course. So this is for me, for our group, this is very nice to see that we will be someone after us.
Thank you.
The microphone for Professora Patrícia, por favor.
Good morning. Thank you very much, Professor Mayo, for a very nice presentation, very inspiring. I'm a clinical geneticist, and I work with hereditary cancer and had the opportunity to work with Dr. Thierry Freiburg, who organized in France the Hereditary Cancer Network. I guess it's a similar initiative. My question for you is, wasn't sure if I understood it right. After you diagnose a patient and a family with a rare disorder, will this patient and family continue to be followed for his entire life in the reference center? Because you mentioned the transition between pediatric care and adult care. The question is there in certain situations a transition between what I imagine is tertiary care and primary care for long-term follow-up? Is this something that you are able to do with certain diseases, or will the patients be followed at a tertiary high complexity level for their entire lives?
Well, they are just for you to know that cancer you saw is not included, even about rare cancers, because there is a national plan for cancer. So this is why. And about your questions, we intend to have most patients follow up in reference or competence centers. So in tertiary care centers, and this is one of the goals of the plan, because they can get updated therapy and everything. They can be included in research programs as well. So this is what we intend. But of course, sometimes we have some loss of follow-up, or some patients, they move and they get lost, but we try to keep them follow-up in our centers. Yeah.
I'm just a bit more curious about this, like the disease-specific networks. This is for care or for research? For me, it was a bit misleading. I don't know if I got it right. So it's...
This is for both. Mostly for care, because remember, it came from the patients. So they ask for a better access of care, but over time, research has grown. And yes, and now, because we have something like a national program, national call every year for research, and there is a specific line funding for rare disease. So when we apply, we can tick on rare disease, and it will go into a different evaluation.
My question is also because, like, taking Ida's comment that in here we have these like overall reference centers for rare diseases. We have some regional limitations, so we can only receive patients from our state. And I'm not so sure if thinking about like rare and ultra rare disease, sometimes we have like some centers that are quite experts in one disease, and they cannot see patients from other states. So perhaps your model somehow, I know that French patients like to have consultation nearby their home, but perhaps we should try to think differently also in Brazil regarding this. Yeah, not everyone will be a specialist in a ultra rare disease in every region. So
yes, this is a huge difference. But remember that the country is small, and even so, the patients, they don't like to move so much. Some patients with very rare disease, sometimes there is, because I saw the networks, it looks very nice and everything, but for some disease, there is only one reference or even competence center. For example, I think for Cornelia de Lange syndrome, I think there is only one center, so they have to move anyway. And sometimes, I'm sure that not every disease are covered with the national plan. So there are also some orphan. I don't like the term of orphan disease, because what I try to show is that you should not use orphan anymore, but there are still some disease, or maybe there is one specialist in the country, or maybe none. And also this is why your remark about people with some disease, they see their doctor, their family doctor, for example, and they, well, what is it? I don't know. They face that very often.
Thank you so much, Professor Francois. I'd like to understand a little more about the electronic system that you showed to us. When you see a patient, you have to include the patient in a research electronic system, or is the medical record that every physician has? access?
So it is different from our medical records. We have, and this is a problem we have in France. Every hospital almost has its own medical records, very different from one hospital to another. And this is a big issue we have to change. Yes, I don't know, but because you know there are many companies who have some medical record system they want to sell. So we have an American one, for example, but they stop. We have to change next year. We are very anxious about this. This will not be the same that the private clinic or the other public hospital, even in a small area. So this is a nightmare. But this, the database, it's completely separated. But this is national. And I think INSERM, the National Institute for Medical Research, is responsible for that. And yes, this is another job we have to do to enter. But to be honest, we have someone to do it for us. We have just to check. But we can make statistics, as you've seen. We can ask. There is a national board, and we can ask. And we also ask the patient's consent to be, of course.
This is me. So Laura Jardim, from here, I'm working with neurogenetic disorders for a long time. Thank you very much, Professor Mayo, for your very inspiring talk. But I was wondering, maybe if I'm change a little bit the focus, my question maybe change a little bit. I was wondering that you have a lot of experience for so many years with genetic disorders that are prone to genetic counseling, and therefore to family planning and for primary prevention. I mean, of course, our countries are very different in terms of what is allowed for a family to perform, for women to do with their pregnancies. But I was wondering if in France you saw differences in frequency of genetic disorders, even in adulthood, based on the perspective of time and therefore to genetic counseling and whatever. Because here we are talking about policies, of health policies. And from the point of view of the population, I would say that genetic counseling should receive more attention in our country, where we have a lot of inequalities, very different from France. Yeah, maybe we have a lot of things that we share, but I think France does not share with us social inequalities as well as I think. So maybe I would like to hear your thoughts about this.
First, be sure that we have inequalities as well. Maybe not the same, but I'm not very comfortable, to be honest, with your question, because I don't know about genetic counseling, and we work with the genetics department. We have a genetic counselor, or is that? But I don't know whether it has changed things over time, because I think it was your question.
My question was, because I learned that you are in the Department of Internal Medicine, as well as myself. So your point is on care, on patients. But I was wondering if you saw differences in disease frequencies in these different decades of your life experiences.
I can't tell you. I don't know.
Okay.
Honestly.
Good morning, everyone. Thank you for the lecture, Professor Milo. My question is regarding the transition process between infancy and adulthood that you have in your center, especially because you talked about you going to pediatrics and pediatrics coming to you, but regarding the subspecialties, do you have any specific policy? How do you transition your subspecialty care? Because here in our center, The follow-up is usually done by the geneticist along the whole life of the patient. And our main issue is transitioning subspecialties, because in the interdisciplinary care, they have neuropediatricians, and then they have to be transitioned to adult neurologists, for example, and so on. So what's your experience in that regard? Thank you.
My experience is only about inborn metabolic disease first, as you can understand. We have no specific policy. We have only general guidelines that I show you. But I didn't talk about, because regarding subspecialties, because of course some patients with IMDs, they have to be seen by the liver specialist. We have also liver transplantation department, neurologist and endocrinologist. So we are structured. I showed you only the core of our team, but we have also many collaborations with neurologists and different specialties. What I would like to try to set up is a multidisciplinary visit, like a patient care pathway, but we did not yet. But that would be nice. This is what we'll deal with the problem of subspecialties. But I know that in some other disease, for example, in our university hospital, the transition process does not work. It works for diabetes, for us, between neuropediatrics and neurology, because sometimes they refer some neurologic patients to me. So I'm not a neurologist. I love neurology. This is true, but I'm not a neurologist. So about liver disease, I don't know. For example, infantile cardiac disease, it doesn't work. This is the same person who is looking after children and adults. So you see, this is not the perfect world.
Somehow comforting knowing that you still face those challenges the same way that we do. So I think we all have to think in a way to engage subspecialties in this transition too.
Yes, this is very important to get into that process. And also, this is very important to have a trust between pediatrician and the other.
Just a quick comment on that. The transition, that's something that I've been discussing in rheumatology in our service for a long time, because I have a rheumatology pediatrician. And what I was discussing is the age of the transition. And I saw that you mentioned 18 years old. But here the pediatrician, they want to transfer the patient only after 20 or 21 years old. So there's been one discussion, what's childhood, when is adulthood, what's the best timing for making the transition. So we are eager to receive these patients, but they're still attached to the patient, they want to transition them.
Yes, to me, the age is not important. More important is the process to prepare patients and families, as I told you. And about rheumatologic disease, the transition works. I have 2 colleagues in my service that do the transition for rheumatologic disease or auto-inflammatory disease as well. But the age, even for inborn metabolic patients, it's sometimes, if they are ready, it's 16. Sometimes it's 21. If they are not stable, we have to wait. For example, we had a patient who was really unwell. She has MMA. Help me, Ida. Methyl metabolic acidemia. and she was on the way to be transplanted, to have a liver and kidney transplant. So we have estimated that it was not the right moment to transfer the patient. So what we did is that the procedure has been started by François, my colleague, but I was involved in every step, in every meeting with, for example, I remember one meeting with the team of kidney transplantation, and also the liver surgeon was there, and I was involved into the discussion. So now I follow this and we are thinking about a second kidney transplantation. But,
Okay, thank you. Hi, thank you for the excellent presentation. I have some questions, but I'll try to be brief because I know it's midday. My first question, you mentioned that you have the process of transfer from pediatrics to adulthood, and I wanted to know if you also have that for the older patients, for a geriatric or even a palliative service involved as well, because we know a lot of our diseases have a progressive and kind of difficult end stage. So that's something we're trying to begin here in our service, a more joint cooperation with the palliative service. So we wanted to know how it works. And the second one, I wanted to know more, how do you engage with the families? If the patient has something, needs a document or something happened health-wise, do they have an open access to the team, or they have the nurse or the hotline? How do you engage with the families or the patients when they have doubts or fever or something happened and they need to know if it's their disease, their metabolic disease, or it's something else? Thank you.
A lot of questions. No, it's fine. But the first questions, could you remember? The
transition for palliative care.
Well, we didn't think about that, but we are not very good friends with the geriatric department so far. So we are mostly somewhat in competition. But this is a nice idea I will get from you, because why not? We have to be open-minded. We do the transition from the pediatric service, so why we shouldn't think about the transition into geriatrics? So, good. Yeah, thank you for the idea, and maybe our systematic review will help, because what we want to show is it does exist in older people for diagnosis, but also you are perfectly right for follow-up. The second question.
How the patients have access to you or to your team when they have complication or they need some reports, something like that?
Yes, they have access, of course. We are organized for that in case of metabolic decompensations. They have a specific number. Some of my patients, they have sometimes my personal numbers they call, or yes, we have. And this is very important because we can't imagine that the pediatrician are able to deal with metabolic decompensations, and we don't. We have to. And this is part of the trust between the two teams. And this is why this is also a long process, because the families, yes, they can meet us. Usually, when at the joint clinic, when I go to the pediatric hospital, the mother, the father, or anyone of the family. They are here. So I met the families. And when they first come, the families are also welcome. And it depends on the patients. I have some, maybe I follow them for 5 years and the mother is still here. So I try to encourage autonomy of the patient, but, well, maybe I'm too soft, I don't know. But usually you see patient once with the mother, mostly mother than father, but also father as well. You see twice, and after 1 or 2 years, they come on their own. And they are not happy to speak about some specific issues about adulthood or adolescence.
Now I think we'll have our last question. Okay.
Ok, voilà, merci beaucoup, monsieur. J'aime bien votre présentation. Je ne suis pas François, mais presque. Alors, switch to English. So, my question is regarding more organizational question about European Union. If I want to know if the French system receive patients from other smaller countries, for example, Belgium or Luxembourg. I'm not sure if Brussels has a Center for Rare Disease, if there are some cooperations in Europe to receive this kind of patients because there are smaller countries. Thank you.
Yes, we have. I just mentioned the story of European Reference Network, but it's mostly about research so far. But of course, we see some patients sometimes. But in Belgium, for example, there are some metabolic centers as well. But what we do is also cooperation in teaching. For example, now, she has finished last week. I had a resident, no, she was an assistant from Liège in Belgium. So she came to us for a 6-week period of learning about metabolic disease, and she is involved in the systematic review that we have imagined. So yes, there are some cooperations, and well, but I think that in the country around France, Belgium, Germany, they have some centers, so they don't need to transfer patients. This is very unusual.
So I thank you, Professor Francois.
Thank you.
For being here with us, Professor Ricardo Xavier and Jonas Salt, and everyone. I think the discussion was great, and I think this is very important for us to point out the importance of rare disease in every discussion about the public health policies, guidelines, and even for we try to become our SUS, the public health system, stronger in this field as well. Okay, so thank you very much.